Welcome to Your Health Matters with Dr. Benjamin Bryant, Chief of Staff and Chief General Surgeon here at UH Geneva Medical Center. Dr. Ben, how you doing today?
Well, I'm feeling the warmth out there.
It's supposed to get up to like, 48 degrees today in January?
Yeah, we're out of the deep freeze for the moment.
Yeah, for a couple days anyway.
A couple of days anyway.
We have a guest today.
Yes, well, today we are going to be talking about a new program that is going to be offered at UH Geneva Medical Center. Dr. Jessica Milliman of Podiatry has very graciously allowed herself to join us today to begin discussing this, and we anticipate that another physician will also be joining, Dr. Michael Brown of Vascular Surgery. And what we're talking about is a wound clinic, a dedicated wound clinic. Now, I think the way we start off, Dr. Milliman, is for you to explain to us what that is. What is a wound clinic?
So there are patients that have ulcers or wounds. It could be anywhere on your body. Myself, being a podiatrist, I focus on the foot and the ankle. I see a lot of diabetic patients, and unfortunately a lot of diabetics will end up having ulcerations, wounds, amputations, and when your system is not what it should be, meaning you're compromised being a diabetic, you can't heal properly, and you can have delayed wound healing. So with that, we are starting a wound care center that can help specialize and heal your wound in the best possible environment. Myself will be working with Dr. Michael Brown, who will be here shortly. Dr. Brown is a vascular doctor. That means he works with your arteries and your veins, and that's really important because that is what gets your blood supply to where you need the healing factors. You can't heal a wound if you don't have blood. So there's only so much I can do from a podiatrist standpoint. So I can make sure your wound is clean, I can put products on to help heal it, but no matter what, if you're not getting if you're not getting blood down to that area, it's gonna slow your growth. So the two of us working together will really help progress your wound to heal in the best possible manner that we would like it to.
That's very, very important. The fact that we have both of these disciplines, podiatry and vascular surgery, involved in this is going to translate to the most effective care possible for these very difficult problems. Everyone in life pretty much at some time or another has had some kind of a wound. Mm-hmm. You know, you fell and you skinned your knee pretty good. Mm-hmm. Yeah, that's a wound.
Right.
All right, or you cut yourself, or you got an infection or something like that. And generally what happens is, you take care of it properly and the body goes on to heal it.
Right.
But in many circumstances, some of which we'll get into, the wound doesn't heal. Mm-hmm. It dwindles along, doesn't really seem to get anywhere. It can actually even get worse. And that's very distressing. I mean, to have to be dealing with that all the time and really not feel like you're getting anywhere, that's a tough position to be in. A lot of people are in that position.
Right.
So if we have the ability to do things to improve that, to actually kind of stack the deck in your favor, mm-hmm. and there's lots of different things that can be done, then sometimes we can move those off dead center and move them on toward healing.
Right.
Frequently will take more time than usual,
right.
But at least you can see some progress and eventually get to closure.
And the best part of having this in Geneva is that we are going to be located in Ashtabula County, and we have not had a vascular surgeon in Ashtabula County University Hospital. So I know, there's patients in my practice that I've had to refer to vascular, and they've had to go, Lake County being the closest. So this is really important for our community because, just the location alone is going to be very helpful. We have a wound care center. University Hospitals has one that's located in Geauga, and they have been open for a couple years, and they've been doing really well. They also have general surgeon there, and that's our hope. We're going to start small, and we hope to really expand. It would be amazing if we can get an infectious disease doctor, a general surgeon, because you can have wounds all over. So right now we're going to be specializing on the lower extremity, but unfortunately there could be wounds on any part of your body, and we don't want to have to turn any of those patients away. So that's going to be our main goal, to have a general surgeon. And infectious disease is also very important too, because with some of these wounds you can have, you have to get put on sometimes special antibiotics, and an infectious disease doctor is someone who specializes that and gets you on the correct antibiotic based on what the culture is. So it could be very in-depth.
Absolutely.
There's a lot of different factors that we have to make sure come together in order to get you on the right path.
Doctor, my wife has something on her bottom of her foot called a callus that has to be removed like every month or two. Is that something that could be, I just don't understand why that cannot be healed and why it has to be taken off all the time.
So that's a pressure point, and that's actually a great question, because a callus itself would not be considered a wound, because that's just thickened skin. So each time when she goes to a podiatrist or whoever takes care of that for her, they're removing the extra thickened skin. They're not breaking skin or creating a wound. So and why does that continue to grow back? It's because of how her feet function and her shoes, and she's getting repetitive friction on that area, and it's your skin protecting the area.
Oh, okay.
Yeah.
Okay. I just didn't understand it, I guess.
Right. No, that's a great question. And that's something, I think as we start, not every, if a patient's coming to a podiatrist, we will then establish if they, qualify to go to the wound care center. So if your wife were to come to me, I would, explain to her why this is done in an office and it doesn't need to go to a wound care center at that time.
Okay.
Yeah.
Would your office handle neuropathy?
Yes.
And is that a vascular thing?
So that's nerves. Neurovascular, they kind of go hand in hand.
Okay.
But yes, we deal with neuropathy. That's more of a numbness, tingling, burning sensation in your feet. That's where you lose sensation, and neuropathy can be very serious in diabetes or in any, if you have back history, that all your nerves stem from your back. So you can have, problems from there. But that's the first thing I do when any patient comes to the office. I assess all of that. I assess your blood status, to see if you're getting proper blood flow to the area. I assess if you have feeling, sensation. We talk about, how you feel. Yeah. So.
Yes, absolutely. Well, we've talked about that on this show before, particularly in diabetics, how difficulties with the nerves and sensation sets people up to injure themselves, sometimes without even knowing it.
Exactly.
And that's a dangerous situation.
Right. Being a neuropathic, you don't have the proper feeling in your feet, so you could step on something, not realize it. You could have something in your shoe.
That's right.
And it's not hurting because you're not getting that pain sensation. Right.
Okay.
So, having pain, feeling pain is actually good, because that's your body telling you something's wrong. And when you don't have that, you don't realize that you're actually in more trouble than what you would expect, because you're not going to feel anything.
Okay.
Yeah, no warning.
No warning.
Not very nice, not very nice. Now, I'm just going to imagine that some form of nutritional counseling will also be represented in the wound center.
Right. We actually, we have a nutritionist that works with us now. Any physician in Ashtabula County can put in a consult for nutrition therapy, and that also plays a huge role too. When there's wound healing delays, we can pull special labs. We can do some lab work to see, are you getting the proper nutrition that you should? And then we can base it on that. Sometimes all it takes is just drinking a couple protein or nutrition drinks a day. But, we need to make sure that your body is functioning the way it should in order to get those wounds to heal.
Absolutely. It's not uncommon for me to see someone with what's called a decubitus ulcer. I think everybody's probably heard of that, pressure ulcer.
On pressure points. So if you know someone that's laying in bed a lot, they can develop them on your heels or elbows, really anywhere where there's not, where there's long-term pressure on that area. The skin just tends to break down and creates a wound after a while.
Our pressure ulcers, they can get to be quite severe, actually. And is this something that will fall under the purview of the wound center. It will.
Yes.
Folks, that's terrific. I mean, that's a very, very big deal, because these, particularly in patients who aren't able to move around very well, who may be cognitively impaired, people in extended care facilities, you have, I mean, great attention has to be paid to those patients to prevent this from happening. And once it does happen, it can be tough.
Right.
I mean, those ulcers, it's not just a skin breakdown. The soft tissue can break down, it can get all the way down to and even involve the bone.
And it's not something that happens overnight. You know, it takes a while for these, you know, pressure ulcers to develop. So then it just takes, you know, just as long, sometimes twice as long, to heal. It's not something that's just done overnight. It takes a while to develop. It takes even longer for it to heal, unfortunately.
They're notorious for that, but they will. They can.
Right.
They can heal. But I'll see somebody in the hospital who has a pressure ulcer, and with some of the routine labs that we get some insight into their nutritional status. And one of the things we look at is called albumin or prealbumin, and that's a protein in the blood, and it kind of gives you a kind of a quick sketch of whether your body is protein deficient or not.
Right.
And I'll see these people with less than half
Of what it should be.
of what it should be. And so then the question becomes, how can they possibly heal a wound when they got nothing in their system to heal it with? Good.
You know, I wanted to ask you where the wound center is going to be, I guess.
It's going to be on the location of the Geneva Hospital. It's going to be right across from the parking lot.
Okay.
There is a standalone building, and that's where it's going to be located.
Oh, okay, I know where you mean.
Yeah.
Very good, that's handy.
Yes.
Easy for people to get to.
And so we won't have it here. I want to just make that clear.
Correct.
So that people don't think that we'll...
No, our patients who require that, if you tell somebody they have to go to Geneva, it's a lot different than telling them they have to go to Cleveland.
Right.
Now, because this is a hospital-based service, I believe you can use the hospital transportation, the bus and the vans.
We'll look into that and confirm that, but of course, that would be very helpful indeed.
Right,
Yeah.
because it can go from, I believe they can even pick up at the Ashtabula Center and the Conneaut Hospital to transport to Geneva and back.
I believe you're right about that. You know, the hospital transportation can't be used to take it to a private doctor's office. But if it's something that's basically a hospital service, then you can. And that's going to make things even more convenient for our Conneaut patients, certainly. Certainly. Now, you know, we take care of some wounds here in Conneaut. Everybody, well, most people know this. There's a certain kind of infection that's very common in our neck of the woods, unfortunately. People hear the term MRSA, MRSA.
Please, code green, code green, code green.
Are we all clear?
That MRSA is unfortunately quite common in our area. And
What exactly is that, Doc?
it's a staphylococcus,
Okay.
which is a usual kind of a skin organism. But if it gets through the skin into the deeper tissues, then a big fight happens between the organism and your immune system. Okay, and if the organism wins, then you get an infection there. You get an abscess, and it can spread, and it can become very, very troublesome, dangerous.
And we can treat that here.
We routinely treat that here. I see an awful lot of it. And usually they're in patients who are mobile, who are not necessarily diabetics, who eat reasonably and their nutritional status reasonably good, don't have a lot of other things going on. You know, and once that, if there's a localized infection that needs surgery to drain it, it's not going to heal without that, okay? But once that's done, those will usually go on and heal with fairly straightforward dressing changes.
Okay.
And that's something that we take care of routinely here. But what Dr. Milliman is talking about is another order of magnitude of complexity beyond that. And we'll go into kind of, and it's not, you know, it's not that hard to understand. I mean, if you've got somebody with a bad process going on in their foot who's a diabetic, That's not a typical wound, okay? That's a complicated situation that requires this kind of expertise.
And that's why it's very important for every diabetic or anyone that doesn't have sensation in their feet to check their feet twice a day, at least, once in the morning, once at night, to evaluate for any skin changes that could be happening. And just to, make sure you know what your normal is. So when you notice something out of the ordinary, you know to monitor it and get ahead of schedule and, call and have it evaluated.
When you say check your feet, like just make sure that,
Look at the top and on the bottom of your feet. Now, some patients can't, are unable to look at the bottom of their feet or
Right.
pull their leg up. So I recommend having a mirror by their nightstand to look, so they're inspecting the bottom of their feet. Also, in between your toes, web spaces, a lot of wounds can develop in there, and those can be pretty hard to treat because your feet are normally closed and in shoe gear
right,
the rest of the day or throughout the day, that it's hard to actually get that area to heal.
okay.
But yeah, it's very important to look and inspect, because you yourself, the patient, are responsible. So you need to be aware of what's going on.
Okay,
Well, yeah, and additionally, if you talk to any diabetic who has wound up with a tough foot problem, and then gone through what's had to be gone through in order to deal with that and so on, and you ask them, gosh, would it have been worth it for you to be able to prevent all this?
Right.
See what kind of an answer you get. That's the point. And the patient himself or herself is going to notice this before anybody else does.
Right. Swelling, if you just notice something turning red, any fluid leaking out of anywhere, that's not normal. Swelling is where something is bigger than what it should be. A lot of toes can look larger than normal. And that is why I have a very, very good relationship with the majority of the primary care physicians in our community. And whenever they have a diabetic, they always send them to me just so I can do an initial evaluation and we go over all of this, because prevention is key. I would rather not have to treat wounds. It
Right.
doesn't have to always get to that.
Okay, joining us now on the show is Dr. Michael Brown. And welcome, Dr. Brown. I know you came quite a distance here to be on the show.
Yeah, thanks for having me.
Well, we appreciate you coming in. Dr. Ben, of course, you're very excited having Dr. Brown here.
Absolutely. It's really wonderful that he would make the commitment to come all the way out here. Dr. Brown was on this show last year. Dr. Brown is a vascular surgeon, a blood vessel surgeon with university hospitals. And he is going to be involved in the wound center at UH Geneva, and already has the wound center at UH Geneva up and running. Dr. Brown, why would a vascular surgeon be involved in a wound center?
Sure, a lot of the wounds that come into wound centers are there because there's a decrease in the blood flow to the person's leg or foot, and my job is to try to increase the blood flow so that we can get that wound to heal that much quicker. In the community, family practice physicians have a tough job of seeing patients, and sometimes they try to help treat wounds, and then they eventually get to a wound center. Sometimes they're healed, sometimes they're not, and there can be a significant delay at times when the blood flow is not interpreted correctly. So my job is to try to do that, to eventually get the wound to heal.
Yeah, obviously, and we made this point before, that if there's a problem with the blood flow, either not enough blood getting to the area or difficulty draining the blood out of the area, it's going to be very, very difficult for that wound to heal.
Absolutely. So there are two types of things that I look at. Arterial, which means the blood flow getting down into the foot. So if you have a lack of arterial blood, that can cause painful wounds. Or venous problems, the veins take the blood back to the heart. And if you have either obstruction, meaning a narrowing in the veins in the abdomen, or if you have problems with the valves in the legs, that can cause higher pressure in the veins, which can put someone at risk of having ulceration, venous wounds.
Yes, unfortunately, those are quite common. I think most people know of someone who has had that kind of a problem with their leg. The leg is swollen, it's discolored, there's a skin breakdown, it can get deeper, and it just seems to dwindle and dwindle along, never really goes anywhere. And I would assume that patients with that kind of a problem would be ideal candidates for the wound center.
Absolutely. Yeah, venous disease is 10 times more common than arterial disease. It's
10 times, my goodness.
you can make a career of just looking at patients with varicose veins, and that's one reason why there are in other states vein centers popping up in plazas next to Walgreens. There's a lot of patients with varicose veins, and at the end stage of venous disease are ulcerations. And you know, if you get evaluated by the appropriate people, we can try to decrease the recurrence of wounds and obviously fix the wound that you currently have.
You have to think, if you have blood coming from your heart down to your feet, if there's any limitation of that, if you're not getting the proper blood supply to your foot, you can get ulcers just from a lack of blood supply. So not getting proper blood supply to the artery. Then you have the veins, which take the blood from the feet back up to the heart. Well, if that's not working, your blood is just getting, built up in your foot and in your leg, and that can create swelling. So there's only so much that your skin can actually handle. There's only so much fluid your skin can handle before it just starts to leak out of your skin. I don't know if you've ever seen a patient that just their leg looks wet, and it literally is because your skin is at its wit's ends and it can't push the blood and the fluid back up the way it's supposed to, so it just comes out. Well, your skin shouldn't really be excreting fluid like that, so then your skin breaks down and you can have an ulcer created just from swelling in the leg, severe swelling in the leg.
And those kind of ulcers require the right kind of dressings and wound care, but they also require other interventions. Just putting a dressing on an ulcer like that is not going to, it may protect it, but it won't allow it to heal. Mm-hmm. It's not going to heal until the conditions that were responsible for it are fixed. Mm-hmm. And what kinds of things, because this is a common problem. A lot of people out there have swelling in their legs, and maybe they have had ulcers or have them now. What kinds of things would you discuss with a patient like that? They come in, you assess them, you see, yes, they do have a chronic venous stasis ulcer, they've got edema in their leg, and so on. What kinds of things do you discuss with them about how that might be approached?
Sure. So the first thing that I do is try to get a history as to, have they had wounds like this in the past? Do they have physical exam as well? Do they have varicose veins? Have they ever had any kind of work done on their veins in the past? Has other physicians been there changing the flow pattern out of the leg? And that can be evaluated easily with an ultrasound, where it's a painless study. They put some jelly on the leg and use a little probe that allows the ultrasound tech to see the veins and then to actually see if the valves are working. We have little one-way valves in our legs that are supposed to promote the blood out of the leg and not to allow it to fall back. And if the valves are not working, not closing efficiently, we will see that very easily on the ultrasound, and then be able to tell the patient at the time of the visit whether or not they have a leg that can easily be fixed by closing the vein. And that can be done in a couple different ways. We used to strip the veins, which you may have heard or had friends or family members that had their veins barbarically stripped in the past.
That's barbaric.
Currently, we don't do that. We use a variety of catheters, either to heat the inside of the vein which is a painless procedure that I used to do right in the office. We currently do it in the cath lab, so we can give the patient some medication for anxiety. And then there's another catheter that has actually just been approved by the FDA that we've used in the past, that looks like a little egg beater, and it spins around at a real high RPM that allows the inside of the vein to be irritated, and then at the same time you inject a chemical to squeeze that vein down and close it.
Okay, so there's really not the incisions like there used to be. There's not the bruising like there used to be. I mean, it used to be a pretty rough procedure to go through.
Correct. Yeah, there's a little incision to get the catheter in. It's typically, once the dressing comes off, you can't even see the incision.
Right. And that's it. And then, of course, I mean, if the problem is that you've got a vein that the valves don't work, so you've got a constant column of pressure forcing fluid out into the tissues, and then you close that vein, you've taken away the inciting cause of that fluid leaking out.
Correct. And then a lot of people ask, well, where does that blood go? You typically only close the vein from about the calf level on up to the groin. And the blood flow that would have otherwise gone up through that vein is getting channeled out through connecting veins at the bottom of the leg into the deeper vein system that does the majority of the blood flow out of the leg.
And if it's going that way into that venous system, then there really isn't any potential for the more superficial kinds of problems that we've been talking about, because it's surrounded by muscle.
Correct.
Right.
Now, if you have insufficiency or valve problems in the deeper veins, that can be a real issue, because there is no currently any surgery to fix those larger veins. That's where we really rely on the wound care physicians to help with compression therapy, which is absolutely crucial in some of these venous cases that can't be fixed surgically.
Well, we did have one of our personnel who works here at UH Conneaut, Andrea Ballo, was on
she's
last
wonderful.
summer. Yes, and she was on discussing UH Conneaut's lymphedema clinic, and we were talking about how the presence of all of this extra fluid really makes everybody's job a lot tougher, and I would anticipate that compression in these swollen legs is usually part of the therapy.
Absolutely.
And compression hose are very common. I'm sure there's a lot of people out there that know someone who has to wear the compression hose. They always get a bad rap because they're difficult to put on, but there's a lot of different types out there now. You know, you can have sequential Velcro, ones that can zip up that provide a little bit of ease of application. So there's a lot of different products that we can use, because compression therapy, you know, trying to keep the fluid up and not just sit in the bottom of your feet and ankles is really important. So if it can't be corrected surgically, then we have conservative measures we can take for that as well.
So if somebody is going to benefit potentially from that kind of therapy, they could be introduced to that and set up with that right from the wound center.
We do a consult to Andrea.
Oh, okay. And she comes to Geneva.
Ye-
Or they could be seen here.
Right.
I
Right.
see. I see.
Matt, you had a question?
Yeah, are there early warning signs that ulcer, or you might be having problems with your bottom of your feet and your legs? Like, for me, I'm thinking cold feet. My feet are constantly freezing. I'll be sweating, literally, and with no t-shirt on, and I gotta have a quilt or a blanket over my feet. Is there warning signs to look for?
So temperature changes, one, color changes. If you notice your feet are more red or blue or swollen, those are some, you know, things we want to look for. The cold feet can also be a nerve aspect, to where you're not getting proper sensation, as well as vascular as well. So it's best to always get evaluated so we could rule out and see why you are developing those sensations.
And my hands are freezing. Every time I touch someone, they jump. But there's nothing wrong with the blood flow to my hands.
Right.
It's not uncommon for people to come into the office and complain, well, my feet are always cold. My husband or wife complains about my feet. That has to do sometimes with just the nerves controlling the blood flow to the feet, where the vessels out at the skin are a little dilated more than they could be, or maybe should be, and that makes your feet cool. But that doesn't necessarily mean that somebody has arterial or venous disease. Venous disease is very slow to progress. It's a disease that once it starts, I compare it to a train on the railroad track. Once it gets started, it doesn't stop. But it takes years, decades to slowly see this. So it's fortunate in a way. It's very common, but 80–85% of people with venous disease have no symptoms. So typically, venous disease starts with a little bit of leg swelling, maybe some swelling at the ankle, the foot, the front of your shin where you push in on the bone and you have a divot. Afterwards, you can sometimes develop varicose veins. But down the road, people will start seeing on the inside of their leg, they'll start seeing some brownish discoloration, brawny edema. You walk down in Walmart, you'll see people when they have in the summer with shorts on, all over the place. They have a brownish discoloration on the inside of their leg. That may not be venous disease. There's other things that cause that, but a lot of the times that's just because the blood is pooling under the skin and not getting out as efficiently as it should. So it tattoos the undersurface of the skin.
Staining.
And once you get that, it's there. But that's another indication of maybe some more advanced venous disease that occurs over a period of years. And then the end result, if you progress this far, are ulcerations. So you have time.
Thank you. Thank you.
Now, if somebody comes in to see you folks, obviously through the history, you may get an insight that tells you, gosh, this person may have problems on the arterial side. They may not be getting enough blood down to the lower parts of their leg. Let's say that somebody comes in and this, from the information you gather, this crosses your mind.
So this actually happened last week. I had a patient that was very in severe pain to her leg. Arterial disease is very painful compared to venous. So when you have a patient that comes in with pain just out of proportion, her leg should not be as, it doesn't look like there's anything wrong. There aren't fractures. There isn't a noticeable wound at this time. But she's setting herself up, for problems. That's when we really have to evaluate the vascular. And, that's when I put in a consult to Dr. Brown and it had to get evaluated, and the patient was not getting blood flow down to her foot. So you can go ahead and speak to that.
How did you determine that?
So when I saw the patient, the initial thing was history, getting an idea as to when this pain started, looking at her foot, seeing that she has a wound on the toe, and then physical exam. It's very easy to see in this particular case she had no pulse at the top of her leg, at the groin level, but on the other leg you could easily feel the pulse. And a pulse, what I mean by that is the artery, as the heart beats, there's a transmission of blood flow and down the arteries, and they expand as that wave of blood goes past. So you should be able to easily feel that. You can do it just by feeling your pulse at the wrist or at your neck. Don't push too hard on your neck though. So on this particular patient, she had no pulse at the groin, and sometimes you can fix a problem like that with a stent or a balloon.
So that means that the artery there has narrowed.
In best case scenario, there's a narrowing that you can sometimes finagle a wire up in the cath lab and put a stent or a balloon in to buttress open the artery to keep it flowing. So when I don't feel a pulse in someone's groin, a CAT scan is done, which is, I'm sure a lot of you've had CAT scans in the past, but it's a series of x-rays that are obtained with contrast through an IV. It's painless for the most part other than the IV. It's very quick, no issues with being claustrophobic because the scans now are so quick and you're not in any kind of a tunnel, so your head is free. And this particular patient had a complete blockage of one of the vessels in her pelvis. So the reason you do a CAT scan before taking them to the cath lab is to evaluate, well, is this something that can be fixed in the cath lab? Because a lot of times you hope you can fix it with a balloon or a stent, but lo and behold, you find out that a complete blockage in that vessel, 4 or 5 inches long, is not something that's going to be able to be fixed with a stent. So she was taken to surgery after the cardiologist did a look at her and made sure it was safe, because my patients, when we do surgery on them, the biggest complication has nothing to do with the surgery, meaning the blood vessels or the incision, but complications from blockages in the heart. So if you have arterial disease in the legs or the neck, there's a high correlation with arterial disease in the heart. So we know that, so we get cardiology to see the patients to make sure they're healthy enough to undergo this relatively simple surgery. So this particular patient had a bypass from the other groin to the groin that was involved with a Gore-Tex tube. This took a couple hours to do, and then at the end of the procedure, while she's still on the table, she had a pulse at the top of her foot and the inside of her ankle, like her other leg.
That was successful. That's what you want at the end of it.
Absolutely. So this morning she has completely normal pulses. The pain that she was experiencing in the foot for some time is completely gone. Now she has a very good chance of healing her wounds ultimately.
So, Dr. Brown, what are some things a patient could do to decrease chance of getting, any arterial disease? What are some factors that would set patients up for problems?
Good question, thank you. So, a couple of things you can do, and then there are a couple of things that you can't change. So genetics is one. Mom, dad, brothers, sisters, if they have a history of high cholesterol or a coronary artery disease, you are more likely at a younger age to have problems with plaque buildup in the arteries. And again, that plaque can be anywhere in the body. The 3 most common areas are the neck, the heart, and the legs. So if you have a problem with the heart, you may down the road have an issue with your legs. So you would want to be aware that kind of the beginning signs that you're having a narrowing in one of the vessels in the legs would be pain when you walk. So calf pain when you're walking in the store, trying to do your job around the house, going upstairs from the basement to the first floor, elicits pain because your muscles are not getting the blood flow they need. Things that a lot of people do that can be changed is what we're all guilty of, is our Western diet. And we've been eating McDonald's and Wendy's for years probably, and I'm guilty of it, but high fatty foods, people are more likely to develop higher cholesterol, which in turn can put you at higher risk of developing these plaques inside the arteries. And the number one culprit that I tell people, and no one likes it, is smoking. Smoking has been shown without a doubt, can't argue with it anymore. The facts are there that the chemicals in the smoke get into the blood and directly irritate the lining, the inside of the arteries, irritate them to such a degree that they develop these plaques within the major arteries in the body. And again, it's the neck. If they're there, you're at risk of a stroke. The heart, you're at risk of a heart attack. And then legs, in the early stages, at risk for pain, which can be debilitating at home, but ultimately, if it's not evaluated correctly, can lead to amputation.
I unfortunately see a lot of patients who have a smoking history, and that is one thing. I know it's common now that smoking causes lung cancer, and that's what we try and prevent. However, a lot of patients don't realize that smoking actually affects the blood, which then affects the feet. So I always try and educate my patients about that, and I always want to encourage them for smoking cessation. And I know it's not easy. It is an addiction, and we all realize that. However, we all try and provide as much help and support in doing whatever we can do to help you, because it affects more than just your lungs. It affects the whole body, and we know, he just said the lungs, the heart, neck, and the legs. I mean, it's pretty important.
Absolutely.
Can't function without a heart. Can't walk without legs.
It really is one of the most significant things that you can possibly do to protect yourself. We all know how tough it is to quit smoking, but on the other hand, I just will make a mention. Dr. Mata, Dr. Mauro Mata, our pulmonologist here at UH Conneaut and Geneva, was on the show a couple of weeks ago, and of course is intimately involved with smoking cessation. And he made it clear that this is one of the things that his office really focuses on, okay? I mean, in terms of the history, in terms of support, medical support, other kinds of support. If you are interested in quitting smoking, he will help you, period. He has a very strong commitment to that. His whole office is oriented that way, and you will be able to find the help and the support you need to really quit smoking. I know people have quit and then have gone back. It's a very common story. It's really, really tough. But if all of a sudden you're connected to somebody who's sympathetic, knows what they're doing, and will provide you with the things you need to really cross that threshold and really quit, I'm sure you're picking up on, from what Dr. Milliman and Dr. Brown have been saying today, how huge this is in terms of protecting you from devastating things. So, your primary care doctor can send you to Dr. Mata. You can call Dr. Mata's office yourself and go in. So anyone who's picking up on this and is starting to really understand, gosh, I've just really got to quit, Dr. Mata's office will help you do that.
Even if you can just decrease anything, anything is a step in the right direction. It's tough to just think of where you are now and quitting, but if you can just look as a, downward, taking it one step at a time.
That's right.
A little bit at a time.
Now, when is the Wound Center going to open?
In 2 weeks.
In 2 weeks.
Yes, we're going to have a slow start. We're going to get some things going, and thankfully with Dr. Brown working in Geauga, he's going to bring his pearl of knowledge, and we'll be able to run from there.
Absolutely.
Yes. Now, if patients are picking up on this and want to come to the Wound Center, how do they get there? I mean, do they have to be referred by their own doctor? Can they come in on their own? Maybe they have a question and it isn't really something, but they don't know, and they need the right opinion. Do they have to be referred by their primary care doctor? Can they come in on their own? How does that work?
I think they can come in on their own. It would be insurance based on if they need a referral, but I believe we would be able to easily attain that as needed.
Yeah, most of the time not, but like you say, you can usually get it.
We are going to have a direct phone number to that location, and we will get that published as soon as that's out.
Yes, and as soon as you have that, send it to me, and I will make sure that it gets announced on the next segment.
Okay, great.
Okay.
So right now we're starting with one day a month, and then we will increase as needed. And like I said, end goal is to get other practitioners and other specialties involved.
Now, we're taping this on the 11th of January. It's 11th today, right?
Right.
So we're talking end of the month,
Correct.
right?
Mhm.
End of January is when it
End of
starts.
January, okay.
Okay. All right. Well, we'll get that phone number to you folks. You know, referrals will be made over to the wound center from the hospital here in patients that we see who have pressure ulcers that can benefit from that kind of intervention. And other things, primary care physicians will be sending over there. And folks, you can go on your own. You know, if you look down and you say, gosh, my leg's been swollen for a long time and the skin is broken down and I'm not really sure where to go with this, now you know where to go with this.
Yeah, and you don't even have to have a wound at that time. This can be used as prevention as well, because we want to
Excellent
make
point.
sure
Excellent point.
that it's evaluated by a vascular doctor and myself as well, and we can tell you what your risks would be and what to expect and what to look for. So you don't have to have a current wound, even, you know, if you're concerned or had a wound in the past, that's enough criteria to have you be seen.
Super. Well, gosh, we'd certainly like to thank you both for coming out and taking the time today to introduce this fantastic new service to our public that's going to be available very, very shortly. We really appreciate your coming by.
My pleasure being here, thank you.
Have a great day.
All right, folks, remember your health matters. And if you have any questions for Dr. Bryant, we run a telephone number, of course, during the show. Or you can email me at nick1@sweet224.net.
And if you do have questions about the wound center and are not sure where to turn, you can call my office number and we'll
Right.
get you steered in the right direction.
I'm hoping by the time this is aired, you'll be able to add the number in. at the end.
Absolutely.
Okay, very good. Have a great week, folks. We'll see you next week.